Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Good morning. And I say that because I just learned that this podcast is actually published at 5 a.m. And I wanted to be the first to say good morning to those of you who waited up so you could be the first to listen. And I thank you for that. My name is Dr. Stephen Fine, and I am recording this on behalf of the CEI, Clinical Education Initiative for New York State Department of Health AIDS Institute. The topic this morning is some new developments in PrEP, which is pre-exposure prophylaxis for HIV. Preventing HIV infection in those who are not already infected has been one of the cornerstones of HIV eradication and ending the epidemic. We've been fortunate to have some really great options for pre-exposure prophylaxis. That is, preventing HIV before the person becomes exposed. Some of the most successful pre-exposure prophylaxis regimens have been oral medications, such as combination tablets of emtricitabine, tenofovir disproxil, or emtricitabine, tenofovir alfenamide. One of the most exciting breakthroughs came with injectable pre-exposure prophylaxis, such as cabotegravir for PrEP. This injection, which is given once every 2 months, eliminates the need for people to be compliant with their oral medication. And because of this, it was actually shown to be superior to oral pre-exposure prophylaxis in some studies. This was mainly due to the ability for patients not to have to adhere to an oral regimen. And they were able to get injected once every 2 months in order to prevent HIV. The current regimens are tremendously valuable, and I can't understate the importance of these interventions in the battle to end the HIV epidemic. However, as effective as they are, and are tremendously effective, each of the current pre-exposure prophylaxis regimens does have some drawbacks, most importantly being the need for compliance with the oral regimens and the need to come in on a relatively frequent basis every other month for the injectable regimens. I'm going to talk about during today's podcast is some new data about an exciting new potential pre-exposure prophylaxis regimen that could eliminate some of the drawbacks we've seen in the previous PrEP regimens. Important to note that at least at the time of this recording, this is not approved for use and is still considered in the experimental or clinical trial phase. We never know exactly when things will be approved, but I do know that because of the novelty and extent of innovation, this will probably be fast-tracked and hopefully will be available sometime early next year. The regimen I'm talking about is twice-yearly lenacapavir. I'm going to be drawing heavily on a New England Journal of Medicine article that was published first July 24th, 2024, and data that was presented at the most recent International AIDS Conference. I think this paper was especially exciting because it's a very novel approach to preventing HIV that could potentially be given to patients only twice a year, that the study population was in mostly cis-gender women who have largely been left behind in previous pre-exposure prophylaxis trials, and due to the effectiveness of the regimen, which in the trial I'll be presenting was 100% effective. So without further delay, let's look at this trial and the results. Lenacapavir is a capsid inhibitor, which is really unlike any other HIV medications to come before it. And although resistance can develop, there hasn't been intrinsic resistance so far because it hasn't really been used very much other than as part of a salvage regimen for deeply treatment-experienced HIV patients with resistance. It's known for its high potency and its very long half-life. And it's because of this, it can be administered subcutaneously by injection twice a year. In this study, lenacapavir for HIV prevention was pitted against a current standard oral regimen of emtricitabine and tenofovir alfenamide. Tenofovir alfenamide in the treatment comparator arm, I think, was very innovative as well because although tenofovir disproxil has been used in cisgender women and proven effective for pre-exposure prophylaxis, tenofovir alfenamide data is less easy to come by. Just to expound briefly, we already know that tenofovir alfenamide has been just as effective as tenofovir disproxil in cisgender men and transgender women but there really hasn't been a lot of study in cisgender women to show its effectiveness. Some of the advantages have been touted for tenofovir alafenamide over tenofovir disproxil are that the tablet is smaller, that there are some theoretical improvements in bone health and safety for the kidneys, but really both of those oral regimens have been pretty much equal in other studies. So the study I'm talking about today was a phase 3 multi-center double-blind randomized trial nicknamed Purpose 1. This trial was notable because it was conducted in both South Africa and Uganda, in regions where the incidence of HIV among girls and young women not receiving PrEP was at least 3.5 per 100 person years in recent trials. So high prevalence areas. The trial design was relatively simple. They screened a population of cisgender women who were not already receiving PrEP and who were HIV negative, randomized them into 3 potential cohorts. The first was subcutaneous lenacapavir, given once every 6 weeks, and a placebo, TAF or FTDF. I will use as abbreviations for emtricitabine tenofovir alafenamide and emtricitabine tenofovir disproxil. The second arm was oral emtricitabine TAF once daily with a subcutaneous lenacapavir placebo every 26 weeks and oral FTDF, so emtricitabine tenofovir disproxil once daily with a subcutaneous lenacapavir placebo. 5,368 women underwent randomization, with approximately 2,100 assigned to the lenacapavir group, 2,100 to the FTAF group, and about 1,000 assigned to the FTDF group. All the study participants were monitored closely for adherence, pregnancy, and adverse events. I'll spare you the details of the demographics, but they're clearly laid out in Table 1 of the New England Journal article. Suffice it to say, these were young women who were sexually active and had a fairly high percentage of other sexually transmitted infections, such as chlamydia, Neisseria, and trichomonas. Let's start with safety and adverse events. This regimen proved to be quite safe with very few adverse events. The most common adverse event was injection site reactions, much like we've seen with other injectable medications, but most of these were mild and were not the cause of discontinuation. Second most common complaint from participants were headaches. That occurred in 13% of the lenacapavir group and about 15% of the oral medication group without statistical difference, and it's very similar to what we see in other placebo-controlled clinical trials. Only 4.1% of the lenacapavir group, 4.4% of the FTAF group, and 4.7% of the FTDF group had grade 3 or higher adverse events, so in other words, very well tolerated. And the only adverse event that was statistically different between the groups was nausea and vomiting, and that was actually lower in the lenacapavir group, 6.7%, than in the tenofovir alafenamide or disproxil groups, which approached 10 or 11%. There was a very low number of laboratory abnormalities in the group as a whole, and most of those were grade 1. Of note, during the study, 487 participants became pregnant. 193 pregnancies were in the lenacapavir group. Congenital conditions considered related to the study drug. There was one incidence of polydactyly in one of the babies born in a participant on lenacapavir. However, that patient already had a strong family history of this condition, and it wasn't considered a result of the drug. So in summary, very safe, very well tolerated, and very effective. Let's get down to the results. The results were quite striking that on June 18, 2024, External Independent Data Monitoring Committee reviewed the interim efficacy data for lenacapavir subcutaneous injection once every 6 months to prevent HIV. At that time, they concluded that the pre-specified efficacy data target had been met and recommended stopping the trial, as continuing might be considered no longer ethical. At that point, all the participants were offered the opportunity to receive lenacapavir open label. As I mentioned earlier, approximately 2,100 participants in each group of lenacapavir and FTAF and about 1,000 in the FTDF group received randomization and treatment. Over the time course of the study, there were 55 HIV infections in the study participants. There were 39 in the FTAF group and 16 in the FTDF group, which remember was only half as large. So really important data coming out of the study was that in cisgender women, The F-TAF was just as effective as the FTDF, but comparatively, there were 0 infections in the lenacapavir group, thus making the twice-yearly injection for lenacapavir, at least in this study, 100% effective for preventing HIV. For those who are interested, the p-value of that study was 0.001. Of note, the women who became infected with HIV on the F-TAF or FTDF group, for the most part, had very low or undetectable levels of those drugs in their blood samples, and most of them indicated low adherence to the regimens. The incidence of other sexually transmitted infections such as chlamydia, gonorrhea, and trichomonas were relatively high, as I mentioned earlier, in the groups, and pretty similar, in fact, very similar in all 3 groups, indicating that there wasn't really much difference in the amount of exposures that these women may have had. Is further evidence that it was the medication itself that was responsible for the statistically significant difference in HIV infections. I think, and rightly so, everybody at the International AIDS Conference where this was presented seemed extremely excited about the results, as am I. Use of lenacapavir subcutaneously once every 6 months really addresses one of the main issues for pre-exposure prophylaxis, which is treatment adherence. With the current oral options, although they are very effective if they're taken properly and consistently, you all know that's extremely difficult to do in many situations, particularly since you're asking people to take medication for a disease they don't yet have. Although generally well tolerated, there are some side effects to be seen with oral medication. In addition, we all know that people's situations change over time and the risk of exposure to HIV may wax and wane. It is tricky to be able to start oral medication at the time your risk is the highest, and perhaps people will discontinue when they perceive the risk to be lower and fail to restart again when the risk goes up. There is no doubt that the oral medications for pre-exposure prophylaxis for HIV are going to remain extremely important for many years to come, and the intramuscular injection, cabotegravir, with its superiority over the oral regimens in some trials, addresses many of the adherence drawbacks and will also no doubt remain useful. I'm really excited that we soon hopefully will be adding this twice yearly subcutaneous injection as another option to help women prevent HIV infections. Although I haven't seen nor heard of any of the data yet, I believe clinical trials are ongoing with cis-gender men and transgender women and IV drug users. We soon find out about the efficacy of lenacapavir to prevent HIV in those populations as well. So hopefully everybody involved in preventing HIV infections will be keeping their eye out for the availability of this regimen, which you can never predict, but I hope will come early next year. For more information, take a look at the New England Journal of Medicine article published July 24th, 2024, called Twice Yearly Lenacapavir or Daily F-TAF for HIV Prevention in Cisgender Women. This is Stephen Fine for the New York State AIDS Institute CEI Clinical Education Initiative. Thanks a lot for listening.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.